I appreciate the opportunity to discuss clinical outcome scales. I do not have any conflicts of interest, and I will not discuss any treatment today. I do obviously receive grant support from NIH. Now, why do we do clinical research? Well, evidence-based medicine has changed the way we manage patients with neurologic disease, and guidelines, which are now the foundation of evidence-based medicine, have created standards of care. The information in the guidelines, and I've participated in writing them, largely comes from clinical trials. And in addition, regulatory bodies such as the FDA and third-party payers such as Medicare are influenced by the clinical trials. So clinical trials really are crucial as we move forward in patient care. Now, one of the components of a clinical trial is developing outcome measures. These are developed in response to the goals or the aims of the trial. These can be clinical measures, or they can be some other surrogate measures such as a CT scan or MRI. These will be both primary and secondary measures. Because I'm a vascular neurologist, most of my discussion will reflect on clinical research in stroke, but they can be used as a model for research in other neurologic diseases. Now, the primary goals in stroke vary. It can be a prevention study such as CREST, where they're trying to avoid stroke or recurrent stroke and reduce mortality. It can be an acute treatment trial, such as the NINDS trial of TPA, which was aimed at limiting brain injury. It could be recovery and rehabilitation, looking at ways to maximize recovery. So we have three large sets of trials in stroke. And the design will then involve several issues. First is that stroke encompasses a broad spectrum of vascular diseases of the brain. Another is the stroke can affect different parts of the brain and produce different neurologic impairments. We have a high rate of comorbid diseases, and there are epidemiological variables. And so generally, when you design a trial in stroke, it will be best medical care plus the new intervention versus a control. So what about surrogate markers in ischemic stroke? Well, we do have the potential for surrogate markers, though we're not there yet. These surrogate markers include changes on brain imaging or recanalization, for example. And then there are biomarkers which are being tested, but yet none of them have reached the point of being a primary outcome measure. The bottom line in stroke and in all of neurology is going to be, is the patient better off having received the intervention that is being tested? Next slide. Now, in other areas of neurology, it is possible that surrogate markers could be used, such as EEG, vital capacity, nerve conduction velocities, some genetic factor, or biochemical factor. I think there's a real possibility that in the future, surrogate markers could be used to support clinical markers in determining outcomes in other areas of neurology. Now, what are the outcome measures that we're going to look at? In non-stroke research, we'll look at mortality, improving neurological status, maintaining independence by slowing progression, and prevention of recurrent attacks. The primary outcome measure will be determined, as I said once before, by the aim of the trial. Now, in prevention trials, the goal is to prevent recurrent events. These can be disease-specific events such as a recurrent stroke, a recurrent bout of MS. It could be new comorbid events that we're trying to avoid, and of course, mortality. If the goal is to prevent progression, we're going to look at new recurrences, new impairments, or neurological worsening, and then a global outcome measure. Now, When we talk about clinical rating instruments or stroke scales, we need to recognize there's a variety of things that we need to look at. Many of the stroke scales have been around now. For example, the NIH Stroke Scale has been available now for almost 35 years. We're going to look at the types and severity of neurologic impairments. A scale like the stroke scale, the NIH Stroke Scale, can look at changes in neurological status. We can use the scores on the scale to influence decisions about treatment. We can use it as an outcome measure as well. So now, what is required for a clinically useful rating instrument? It must have credibility. It must be germane to the clinical situation. It must be widely used and clinically useful. In short, the results of the scale should make sense to both healthcare providers and the public. A knowledgeable person should have a mental image of the patient's status when given the score on a stroke scale or any scale. For example, if a patient is coming in with a Glasgow Coma scale of 5, everybody on this conference call should have an image of a profoundly affected patient with a head injury. Similarly, if they come in with an NIH stroke scale of 25, we should recognize that as a major stroke with a patient at high risk for complications or mortality. So we should be able to have a good idea as to what the score means. Next slide. Now, how do you develop a clinical rating instrument or an outcome scale? This is a complex process that requires thought. We need to know the purpose of the scale. Is it measuring impairment, disability, or not? We need to know the information that will be gained. It must be relevant to the assessment of the patients. Generally, a clinical rating scale is based on the patient's performance, and it may include both history and examination. For example, the modified Rankin scale is largely determined by history, while the NIH Stroke Scale is by examination. We need to define how the scoring of the new scale will interdigitate with other rating instruments. In short, there needs a clear plan for testing and validating the instrument that will be used. Now, what are the attributes of a useful clinical rating instrument? It should be easy for the patient and the assessor. It has to be doctor-friendly and patient-friendly. It cannot take too long or be too difficult. The scoring of the scale and how to assess it should be straightforward, with clear instructions on the use and scoring of the scale. There should be inter-rater agreement that's high and intra-rater reproducibility that is high. In short, the scale itself must be valid and must be something that people can do easily and repeatedly. This requires educational and certification programs. In clinical trials, there's an extra requirement, which is especially true for multi-center clinical trials. We need to know that the scale is administered correctly around all the centers. We need to know that the scoring is accurate and consistent around all the centers. In short, a well-validated scale will need to be used. In addition, besides the education and certification of the centers, more recently, clinical trials have developed central adjudication. For example, in the recent trial of intraventricular TPA for treatment of intraventricular hemorrhage, we did videotapes of the outcome assessment and sent them to a central adjudication panel, where I must say they scored patients differently than I did. Next slide. Now, there are several researchers on the call who likely would like to develop a new clinical rating instrument. I would encourage you not to do so. The process is time-consuming and may not be successful. In short, the new scale may not work. In addition, third-party funders, such as NIH, may not be excited about a new unvalidated scale, and it may, in fact, hamper your funding chances. It also delays the primary goal of the project, which is to test the intervention that you are going to examine. It is best to adopt or adapt current scales to your trials. So in short, let's not see new scales coming down the pike in this project. Now, the general organization of clinical rating instruments includes grading the severity of the illness, acute responses to treatment, and then longer-term outcomes. Now, there are terms that you're going to hear about: impairment, disability, and handicap. I use the analogy that impairments are what people have as a result of an event. For example, I've had a spinal cord injury, so I have impairments in my limbs. I am disabled because I cannot do some of the things that I used to do before, and am handicapped because my role in society has changed now that I have handicapped parking places, etc. The impairment may not be the same as disability. For example, if two people are out cutting wood in the forest and both chop off their right hand, the vocalist may have the same impairment as the pianist, but obviously the vocalist does not have the disability of the pianist. Generally, there are two types of scales that you will see: numerical scales based on a total of scoring components of assessment, and a single score scale, which is based on an aggregate of all information rather than scoring individual items. I'm going to go over two of these scales that are widely used in stroke, and because they both have are models of each of these. Now, numerical scores add several items and add the scores together to give a total score. The total score may represent a different combination of items. Depending on the scale, a high score may be good or bad. Let's go over the example of the NIH Stroke Scale. All components of a single score will range from put together to give a score that is good or bad or ugly, depending on how bad it is. Each score has specific and defined criteria. Generally, the higher the score, the poorer the outcome or situation. An example of this would be the modified Rankin scale. Now, in addition, there are modality-specific scales. These are generally used in rehabilitation and recovery and emphasize recovery or compensation in a specific activity, such as walking or hand function. They often do not provide an overall assessment of the patient's autonomy. Now, global outcome measures are generally used by third-party payers and the government because they will define favorable from unfavorable outcomes. These in stroke have been used in both acute and recovery trials and measure impact of multiple neurologic impairments and disabilities. However, such global measures may miss discrete areas of neurologic disability and may overemphasize some components of recovery, particularly motor, and often have ceiling and floor effects. In addition, global measures of outcomes usually require much larger clinical trials. Now, when we move to neurologic impairments in stroke, these are used to assess the baseline severity of stroke, which affects prognosis and decisions for treatment. For example, many of the recent stroke trials have limited enrollment based on the baseline NIH Stroke Scale, with patients with very mild stroke maybe being selected for treatment or excluded, and patients with very severe strokes on an NIH Stroke Scale of, we'll say, greater than 25 often are excluded. In addition, the NIH Stroke Scale will allow measurements of improvement or worsening. As I've mentioned earlier, the NIH Stroke Scale is the most commonly used instrument for rating neurological impairments in the setting of stroke. It was developed by researchers at the University of Cincinnati, University of Iowa, and NINDS back in the 1980s. Next slide. So there are 15 items on the neurological exam. Each item is independently scored. That will get a baseline severity of the neurological impairments. The scores range from 0, which is normal, to 42, which is the highest possible score. Initial testing of this back in published in 1989 showed a high inter-rater agreement and a high test-retest reliability. It also showed that total scores were correlated with the size of infarctions on CT scan. Subsequently, the scale was used in multiple other trials and has been translated to other languages as well. Next slide. Now, what we have found is that the total score of the NIH Stroke Scale generally picks out prognosis, with 0 to 3 being mild and anything above 20 generally being very severe with poor outcomes. Next slide. We also saw that it was prognostic importance. This is our trial from our TOAST study, which shows that depending on the severity of stroke, you can see how patients had excellent to poor outcomes, with generally patients with a score greater than 20 having a very poor chance of recovery. Now, there are advantages of the NIH Stroke Scale for stroke research, and there'll be similar things with some of the standard scales and other aspects of neurology. It is a well-validated measure of stroke severity. It can be performed rapidly. There's good correlation with outcomes. It can be used for both acute and long-term care planning. It has high inter-rater agreement and inter-rater reproducibility. It can be administered via telemedicine, and educational and certification programs exist. Now, there are disadvantages of the NIH Stroke Scale. And this is one that, as an author, I readily admit. It's biased towards the left hemisphere. Scores are higher with left hemisphere stroke than with right hemisphere. There can be a range of scores among raters. Some of the items do not work as well as others, particularly the scoring of ataxia, facial weakness, and aphasia can be difficult. To address this, there have been certification programs developed for the NIH Stroke Scale. We did one in the early 1990s. That's the paper by Albanese, and Pat Lydon and his colleagues at UCSD did one to come up with ways to remediate and to actually certify our raters. And the National Stroke Association found that there are a range among raters with, once again, aphasia and facial weakness being the most problematic items on the scale. Next slide. So where are we with the NIH Stroke Scale? There have been multiple attempts to come up with ways to modify the NIH Stroke Scale, but the original version remains the standard. It is now the most widely used clinical research assessment scale of stroke severity in the world. It's used both in research and clinical care. National guidelines provide recommendations based on the NIH Stroke Scale. It is stroke like the Glasgow Coma Scale or score is in patients with trauma. If you're going to do a stroke trial in one of your research projects, at the present time, you should not plan on replacing the NIH Stroke Scale with something else. It is the standard outcome, clinical outcome measure, and also a standard measure for severity for patient entry. Now, global outcome scales have been accepted by the medical community, government regulators, and authorities. These are used in both acute and recovery studies. These are more useful for testing medications that would have an impact or any other intervention in multiple areas of the brain. Now, they may not be particularly sensitive to important improvements, such as discrete areas of neurological recovery, and they may have ceiling and floor effects, and as I mentioned earlier, may require larger trials. The most commonly used stroke outcome measure is the modified Rankin scale. Rankin developed this in the 1970s and early 80s. It was modified by adding another category later on, and so there are at present 6 categories. It is internationally accepted and widely used in stroke studies. It tells about the status of the patient. Unfortunately, it emphasizes motor limitations and walking. Still, it gives different scores and levels of recovery that can be understood by the public, by physicians, and governmental bodies. The scores are 0, no symptoms at all, to 6, dead. The no symptoms at all is a very hard score to get if you really look at it. So that if somebody goes hiking after a stroke and does well, but by the end of the 5-mile hike has a little dragging of the leg, that would move him down to a score of 1. So it is very hard to achieve a 0. The real goal has been separating 0 and 1, or 0, 1, and 2 from the other scores: moderate disability, moderately severe disability, and severe disability. If we look at how this has been done, you can see that in a review of series of reviews of the modified Rankin scale, we found that the inter-rater agreement is fairly reasonable. But as you go down, you can see there are problems with reliability with this scale as well, even though it is all can be done by direct asking of history. Next slide. Modality-specific scales are primarily used in rehab. It's looking at a device or local intervention and may involve impairments that may improve at different rates. These can generally be done in smaller numbers of patients, but they have not much information about overall outcome, and these may not be understood well by the public, by clinicians, or governmental bodies. Now, one of them is the Pupil score. This has been used by physical therapists. If you look at it, there's a score of 226 points, with each item rated from 1 to 2. If you go through there, you can see how many things that have to be checked. It takes 45 minutes to do this assessment. We have done this with trials at Iowa, and neither the administrators nor the subjects were very happy after the end of the first assessment, and the enthusiasm for sequential assessments was not great. Now, there has been some attempt to break up this into smaller components that might be more palatable. In addition, if you ask a physician what the Pupil score is, most of them will have no idea of what this score is. Now, I'm not bad-mouthing the Pupil score per se, but giving you the idea that you have to be very careful about what scales you pick. Another scale is the Montreal Cognitive Assessment, obviously looking to detect mild cognitive impairments. This takes approximately 10 minutes by direct observation. You cannot do this over the phone, and it tests a variety of higher cognitive functions. You can do this in an outpatient clinic. Now, we've not used this in stroke trials, but I think there is a real place for this. And this may be more sensitive than the mini mental status exam, but may be less specific. The Barthel Index, which is one of the scales we used in our first clinical trial, is based on reporting from the subject or caregiver. It does not require much training. There are 10 items that are scored, 0 for unable to do, all the way up to 10 to 15, depending on whether the patient is dependent, partially independent, or totally independent. The scores range from 0 to 100, with 95 and 100 being no disability, institutionalized under 60. Once again, this is a very heavily weighted towards motor function. Now, one of the nice things that it does test things that are important, such as being able to climb a flight of stairs, or being able to go to the toilet on their own, or being able to eat on their own. Unfortunately, it's relatively insensitive. Still, healthcare providers understand what this means, and it can be an important secondary outcome measure in stroke recovery trials. Another scale that is now becoming more widely used is a quality of life measure. These are being used in a variety of therapies in neurology. It covers a broad range of functioning from physical recovery, psychological health, social status, and general health. This generally is influenced by the person's experiences. These have not been the primary outcome measure, but are a supportive one. The two most commonly being used are the Euroqual and the Stroke Impact Scale. The Euroqual is a simple and brief self-administered instrument. There are five dimensions that are checked for mobility, self-care, usual activities, pain or discomfort, anxiety, and depression, with 1 being no problem and 3 being severe problems. In addition, a scale is given where the patient, with 100 being the best possible score to 0 being the worst imaginable, they're supposed to mark a line where they think they are. So this scale, the Euroqual, has been used, and I think it's got a real promise for a wide variety of research trials in neurology, not just stroke. The Stroke Impact Scale is a little more complex. It involves multiple domains of stroke recovery and is reported by the patient, rated 1 for worst to 5 best. And as you go down there, you can see a huge number of components that are checked with a wide range of activities that are scored. This takes a longer time to do and has not yet been as widely used, in large part because of the complexity of all the components in the quality of life measure. Excellent. Now, to help coordinate studies and to compare them with other research programs, NINDS has made the following recommendations for patients, for researchers to do trials in stroke. For neurologic impairment, the NIH Stroke Scale. For functional status, the Barthel Index and the modified Rankin scale. For emotional and cognitive studies, the Montreal assessment, trail-making tests, and a depression scale. For quality of life or participation, the Euroqual, and for performance, walking speed. The European regulatory bodies have come up with something quite similar. Functional outcomes, Barthel Index, global outcomes, the modified Rankin scale or Glasgow outcome scale, and neurological deficit scales, the Scandinavian Stroke Scale, Canadian Neurological Scale, the NIH Stroke Scale, or Unified Stroke Scale. So what do we have? Currently, we have a wide variety of clinical scales to use in research. I've shown you the example of some of them in stroke. Multiple other neurologic diseases have similar scales. Remember, the selection of the scale for your research project should be influenced by the face value of the scale, its internal construction, and its ability to be reproduced. You need to select, these scales will be used to select patients for enrollment in the trial. You want a scale that is reliable, that is precise, that is valid, that is feasible and acceptable. The choice of scales should be influenced by the primary aim of the research, an acute versus long-term intervention based on the duration of follow-up, the nature of the intervention, and the primary hypothesis. Remember, we look for halting worsening of the disease, improving outcomes, looking at adverse events related to the intervention or not, and any new events that occur. The trial must have measures to ensure accuracy of these outcome measures. This means that you have to select sites that are going to be carefully done. You will then need to certify the investigators. You want to use the scales for patient selection in the trial, for periodic follow-ups, for endpoints and outcomes. Now, there are ways to get around this. You can do central assessments of outcomes with in-person interviews, via telephone construct, videos, or teleconferencing. And finally, now with accuracy, we have now adjudicated endpoints and outcomes. This is particularly true in a trial that cannot be blinded because of the nature of the intervention. Excellent. So in conclusion, we can provide a quantitative element to a complex situation using a scale. A scale score fosters communication among healthcare professionals. It will give you a way to describe your results in a way that is clinically meaningful. Hopefully, at the end of your trial, when you show your results in using scales, both the researchers and clinicians will have an understanding of what these scores mean in these instruments. And I thank you for your attention. I know I went through this fast, but I wanted to save a good portion of the time for a discussion. Thank you.
Thank you, Harold. That was great.
Thank you, Lori. What happens next?
So I think, hey, this is Will Moyer at the University of Michigan. Thank you so much for this talk. One of the participants has put a question into the chat box in the right. I will state it.
All right. I don't have my glasses on, so I could look nice.
Yeah, no, I'll read it. In epilepsy studies, we frequently use seizure frequency as a primary outcome and quality of life as a secondary outcome. It seems to me health-related quality of life might in some cases be a more important outcome. This might be especially true in studies of psychogenic seizures, where the seizures themselves are not very dangerous, but patients are very disabled and have very poor quality of life. What are the drawbacks to using quality of life, HR qual, QALY-10, QALY-31, et cetera, rather than seizure frequency as the primary outcome?
Well, I am not an epilepsy specialist, but given the scenario of the psychogenic epilepsy, I would think you would want to do both, that you would want to both have quality of life, and I guess that could be first if it's well developed and very carefully measured, and there's a way to avoid bias and suggestibility, and then seizure frequency or spell frequency as a second. The advantage of the spell frequency is that's a harder endpoint to define. I mean, it's an easier endpoint to define and a harder endpoint as far as construct. Quality of life measures, particularly in patients who are suggestible, could be really very fuzzy and very hard to determine the validity, because you're going to be dependent on the patient himself or herself of describing what it is. And there's an element of squishiness in that scale. I would still use, probably in most cases, the number of spells as the best outcome measure.
And the other challenge with number of spells is some of there are statistical challenges with that because people can be starting at very different places regarding spell frequency. So reduction.
That's absolutely true. And the nature of the spells may vary as well.
Dr. Conway had another question about composite outcome measures. This is maybe a little too general. What do you think about composite outcome measures?
Well, I want an outcome measure that makes sense to a clinician. So when they see this outcome, they will have an idea as to what the patient is like. That could be neurologic impairment. That could be activities of daily living, whatever it is. I get very concerned when several things are mixed together because then it gets very hard to define what is driving the changes between the treatment groups. So I'm not very excited about composite outcome measures.
I will say that they are sometimes popular in some large cardiovascular studies as a way of getting a larger event rate, but they frequently, as we consume them at the end, we're like, well, the stroke rate went down, but the overall composite didn't, and we have challenges with multiplicity and interpretability.
Absolutely, I would agree with you.
So Dr. Mystery has a good question that she's calling me out too on, but I'm going to make you answer it first. What about surrogate imaging markers such as final infarct volume now that we have a lot more reperfusion studies in stroke with a baseline estimate of potential penumbra and also volume change for say, ICH?
Well, I think they're coming down the road. I don't think we're there yet. One of the problems always is where the lesion is. So I think all of us who've been in stroke have seen patients with moderately severe stroke from a small lesion, for example, in the internal capsule or brainstem. And so it's very hard with volume alone to differentiate. Now, if there can be a very careful selection process, then it may be. And similarly with revascularization now with endovascular therapy, there's increasing evidence that with early revascularization and good revascularization, outcomes are better. But once again, revascularization is going to be a secondary measure to how the patient does clinically. So I don't think volumes of lesions on MRI, for example, have yet reached the point to replace clinical outcomes. I've always used the phrase, the surgery was a success, but the patient died.
I think sometimes we get sort of cancer jealousy in that they can use tumor progression or regression or change as a sort of immediate marker that there is some biological activity, whereas in neurological outcomes where disability is the outcome, it's harder for us to get earlier measures of the potential biological effect.
Well, several years ago when we designed the trial where we were testing an antiplatelet agent, we came up with adjusted outcomes based on the baseline severity. For example, a patient that came in with an NIH Stroke Scale of 15 or above, it's going to be very hard to get to a score of Rankin score of 0 in that patient. And that we would say, well, if it got to a score of 2, we would accept that as a favorable outcome because at least they're not in a nursing home. And if they had a score of under 10, we would try to go for a 0. So there are some ways to adjust responses. We took that based on what they have done in cancer, where 5-year survival, the other outcomes depend on the baseline severity of the tumor. So I think some of that is possible.
And I think the follow-up question was, looking at volume of change of say, lesion in endovascular only patients. I'll take a little bit of my stab on that. One of the issues there is we don't have a stable estimate as to how big that initial infarct is really going to be. And because it can be wildly influenced by how successful the procedure is to pull out the clots. If it's something, it offers a lot of patients who are going to get a lot better because of the reperfusion and limited opportunities to see the new treatment doing something additional because those people are doing so well. that's a challenge, although there are people who you don't take for endovascular because of a disfavorable core, and they may benefit from studies that look at, and I think I've mentioned this in a couple small groups, where you're looking at seeing if you can slow that progression or limit that infarct size. But again, we don't have enough good prospective data on those infarct growth models to really know how well they predict right now. Did you have any other thoughts on that, Dr. Adams?
No, I really don't. I think you did a good summary.
So Dr. Coleman has a question. Sometimes trialists have to choose between the outcome measure that truly best measures what the trial hopes to achieve versus the outcome most accepted and recognized in the field. In stroke, the MRS is so ubiquitous that it is often chosen, despite its weaknesses, over lesser known options that may be more sensitive. What are your thoughts on how to handle that decision?
Well, one of the reasons that the MRS, for example, is used so you can compare data between trials or among trials. So I don't see either the NIH Stroke Scale or the Modified Rankin Scale disappearing at present. Now, if you have a more sensitive outcome measure that may be useful, and it is used as a primary outcome measure for the design of the trial, and it has some cachet in the community already, I guess it could be used instead of the modified Rankin, but then I would still keep the modified Rankin as a secondary outcome measure so that you can compare your results of the trial versus others that are in the public.
I think one of the other unique challenges with the modified Rankin score is that it's an interval scale, or it's an ordinal scale, but it's not interval, in that the transition states are not really evenly spaced in terms of their significance, and as such, it becomes challenging to analyze it in a way that captures those things. I think that, and on the on the good end of severity, similar to your pianist versus vocalist analogy, there are things that I could do if I had a small stroke, like suturing, that I would be still probably very good at, unless it was in my fine motor area. But if it was in my cognitive processing area, I could still do the suturing, but I would have a hard time doing telestroke or other parts of my career, and that those sensitive outcome measures maybe aren't capturing those. The modified Rankin is somewhat too blunt of an instrument to capture those things, but it does. You do want to focus on what's important, and one way that has been proposed, at least, to sort of reinvigorate the modified Rankin somewhat, is to use the utility-weighted modified Rankin, where the jumps between states are measured to how people have measured health utility in one of the recent endovascular trials.
One of the issues with scales is the more the number of subcategories, the harder to get inter-rater agreement.
Yeah.
So the more you expand something, the harder it gets to be to get people to agree. Second thing is, the more scales you have, more scores you have, it gets harder to really be convincing. For example, if a score of 75 really is that much better than a score of 70. And so we have to be very careful about how we design these scales. And yes, the modified Rankin has criticisms. So does the NIH Stroke Scale. But every time an attempt is to try to get it better, the attempts are not as good as we'd like to believe.
I guess that sort of goes back to, like, before we had the NIH Stroke Scale. Then why did it turn out so well for that? How do we do the next thing like that?
It was pure serendipity that it turned out so well. Before, when we were designing it, when Tom Brott, John Marler, and the group here at Iowa were working on it, we looked at items that we thought were important in the NIH Stroke Scale. When we first developed it, for example, we had pupillary response and Babinski sign as we were working on it. And we realized those were really not clinical outcome measures. We threw in limb ataxia so we would have something for cerebellar infarct. And we frankly did not realize that the score was going to be as robust as it was. Because if you're going to do a scale, you're not going to have a scale that goes 0 to 42. you're going to have 0 to 50 or 100 that sounds much better. And so when we started doing the aggregate scores and found out how it worked, we were pleasantly surprised. And of course, the name NIH Stroke Scale does not hurt either.
It looks like Dr. Guttman has a question about commenting on the use of outcome measures developed for other diseases being applied to new diseases that they weren't initially intended for.
Well, that would depend on the nature of the old disease and the new disease. For example, I would think it would be fairly difficult to use some of the stroke information and scales in a disease of some degenerative process, because the aim in a slowly progressive degenerative disease may not be to improve the patient, it may be to halt worsening or extending length of independence or something much different. Now, in some of these circumstances, there may need to be new scales, but I'd be very cautious about developing. And I would look at scales that are similar to, for diseases that are somewhat similar to the new disease that's going to be studied. For example, some neurodegenerative diseases that have peripheral nerve and muscle disease may be able to use scales that are used for Charcot-Marie tooth or something else. Similarly, some central nervous system degenerative disease may be able to use scales that are used in patients with Alzheimer's disease or Parkinson's disease to use.
I think one example from some work that I'm doing, has been the application of the modified Rankin scale, a measure of post-stroke disability, to survivors of global ischemia or cardiac arrest. It has its quirks in that at the ends it works pretty well, but because of the lack of specific focal motor deficits for people who've had global ischemia, it introduces some challenges, but it's been used in some clinical trials and has been thought of kind of carefully by the neurocritical care community as a reasonable outcome measure post cardiac arrest.
One of the other problems with the Rankin scale is it does not really have a good cognitive component. And with patients with global ischemia, I would think something such as the Montreal cognitive assessment would be much better, or would be a reasonable addition to the modified Rankin scale. And that's right, maybe a combination of scores need to be looked at. When we developed the TOAST study, we had to get an excellent outcome. You had to have a good outcome in the Glasgow outcome scale and a good score in the Barthel Index. So you had to have a twofer.
Yeah, that's a really good point. And that the areas where there's lack of I guess, assay sensitivity are often in that good scale. The MRS may overcall good because it undercalls cognitive problems, and then having the second step in those where it's measurable, because in somebody who has severe disability, getting those separate gradations isn't as important in terms of determining what their level of disability is. There's another comment about the use of subscales from a full scale or outcome measure. Like, are there potential dangers in that?
Well, it would depend on the nature of the subscale that's being used and what the purpose of the subscale is being. In effect, some of the modality-specific outcome scales, like used in physical therapy, are really looking at only one or two functions, and such as ability to dress yourself or something. Now, that's an important outcome measure, but it may not fit in the overall. Let me start over. It may not describe the overall status of the patient.
And I think Dr. Conway was commenting that the kind of combination of the MoCA and the MoCA and like the MRS that we're positing may lead to a composite outcome measure, but that might be a good thing, and that has worked out well in a composite outcome in myasthenia.
All right.
All right, so this is like the popcorn popping in the bag or the popper for people old enough to remember popcorn poppers. Um, we're seeing if there's any more questions coming through.
I have to have gray hair to remember developers.
Um, so here's a good question. Any thoughts on automatic movements? Um, I think this is the idea of range, amplitude, acceleration, timing measurements by accelerometers. So in terms of this being a patient and device report, like a device reported outcome, is level of activity. Can you use that as an outcome measure?
Well, I think you can use it as an outcome measure, but it would be a secondary outcome measure to me, because if you have something like that and you report it to the public, colleagues are not going to have any idea of what you are trying to define as a response to therapy.
The one other sort of point I will put on that is that in this smartphone era, for people who are possessing smartphones, that when people have an app related to a clinical trial on their phone, and the phone is set to know whether that phone is active and has moved, if somebody's phone doesn't move for 3 or 4 days, it's actually highly likely that the person is dead, because most people, if they've lost their phone, they'll get it replaced, but or they'll press a button or whatever, they're gonna find it. So that there's some time period that's surprisingly short, that people in the modern age are addicted to their smartphones, and they're most likely to be dead if the thing doesn't move anymore. So you could potentially get a mortality, which is the most objective and easy to measure of outcome measures through that surrogate of smartphone stops moving.
Yeah, but even mortality could be subject to troubles, because you'll have to decide whether it's mortality related to the disease in question or it's another cause of mortality.
Right.
Such as in Detroit, having a victim of violence rather than a new heart attack or something.
Right. Or exactly. So right, and that becomes challenging in terms of the attributability of the mortality, particularly for chronic diseases,
Right.
where there's more competing risk. Whereas in stroke, a lot of times the mortality is often to be attributed to the stroke in the people with the disability from it.
One of the reasons we picked 3 months as the time for outcome measures in stroke, and we did that in our first clinical trials, was that was about the time when somebody who had a stroke could get disability from Social Security, because Social Security had already determined that was about the time of maximal recovery. And longer term outcomes got to be confusing, because we then had concomitant diseases coming in, like heart attacks, or people would die and we would no longer have the ability to detect whether the initial treatment worked. So the 3 months, which has stood all this time now for 35 years, was actually taken from information about when people were declared disabled by the government.
All right. Well, I think with that, I will hand things back over to Joy to put up she can put the link for the evaluations and other things. But I want to be the first to thank Dr. Adams for a fantastic and inspirational talk, and we really appreciate your time today.
Well, it's my pleasure, Bill, and thank you very much for inviting me. I hope this turned out to be a worthwhile session.
Definitely. All right. So I just need to pull up the link. You've got it for the last session in terms of our evaluations for the webinars. I think it should be in some of yours. Oh yeah, the calendar appointments. So it's in the calendar appointment, but I'm going to put it up here in the box too for those of you who haven't seen it today. And again, we look forward to for those of you who are in the project-based part of our course, we look forward to your further work in the small groups, and we look forward to talking to you again next week. Our next webinar session is a little bit, let's see, it's on Monday the 25th is I think we have one of the office hours sessions coming up next week, and there will be no webinar the week of July 4th. So with that, if Joy had anything else? All right. Well, everybody have a good rest of your afternoon.